Hello, my name is Juanita Crook. I'm a professor of radiation oncology at the University of British Columbia, and I'd like to spend the next 15 minutes talking to you about a biochemical definition of cure following brachytherapy for prostate cancer. The interpretation of post-radiation PSA values has always been challenging. Back in 1996, ASTRO convened a consensus conference to define biochemical failure and came up with the definition of 3 consecutive rises after the PSA nadir, within a failure backdated to midway between the nadir and the first rise. And this was used for several years, but there were a lot of problems with this, mainly because of the backdating and the waiting to achieve the 3 rises. And so in 2005, they convened another conference, this time in Phoenix, and that time defined biochemical failure as a single threshold point of when the PSA reached 2 nanograms per mil above whatever nadir had been achieved after the radiation. And that's still used to this day to define failure. Neither of these definitions is meant to be a trigger for intervention. It's just a trigger of reporting results, and you still follow the patient after that failure to whatever clinical point you think you might want to intervene. Also, neither of these conferences attempted to define cure, and neither definition can be compared directly to a surgical series. So, in 3 decades of LDR brachytherapy, what have we observed in PSA behavior? Well, this is some work published 10 years ago from my experience at the Princess Margaret Hospital in Toronto, using brachytherapy for over 1,000 patients. And I determined that at 48 months, the median PSA was 0.2, and out at 96 months, it was 0.04. And you can see the decline and the maintenance of that very low value. The rate of decline can be variable. It will depend on the dose of the brachytherapy, the Gleason score of the cancer, and whether or not the patient goes through a bounce. We looked at the importance of that PSA nadir in LDR brachytherapy using the British Columbia brachytherapy database for 1,400 men, and this was published by Lowe et al. In 2013. And what she reported was that if the PSA at 4 years was less than 0.2 or 0.2 to 0.4, then the patients did very well. And you can see in the 2 top graphs here that there's sustained disease-free rates out beyond 12 years of better than 90%. If it was between 0.4 and 1, not everybody failed, but they didn't do as well. And if it was greater than 1, the majority are going to fail. So this were results based on the PSA at 4 years. What does PSA do after LDR brachytherapy? This was published by Tetro Laflamme in the Journal of Urology in 2018. And again, we used the BC Cancer database and looked at 2,300 men who'd been treated with LDR brachytherapy. 41% had had low-risk cancers, 59% intermediate risk, and half of them had had 6 months of androgen deprivation combined with their brachytherapy. The median follow-up was 89 months. And we classified the PSA in follow-up as either stable, rising, or a biochemical failure, which met the nadir +2 definition. And we found that 86% of these patients were cured. Their median PSA at 5 years was 0.04, and they'd had a nadir of 0.03. So you can see what an ablative treatment LDR brachytherapy is. 6% of the men had a rising PSA, and their median PSA at 5 years was 0.27, which is still quite respectable. Their nadir had also been higher at 0.16. And the 8% with biochemical failure clearly were distinguished because their nadir was much higher at 0.5, which is obviously not low enough for sustained results. If they'd not had prior ADT, and 50% of the population had, what were the predictors of failure? Well, the strongest predictors were their 5-year PSA and the nadir, with odds ratios of 18 and 20. And if you applied these predictors to the PSA group, we found the threshold for failure at that 60-month marker PSA was a PSA of 0.3. And this had a sensitivity of 85%, specificity 98%. So a 0.3 PSA at 5 years is a sign you're probably going to fail later on. And 10% of the 82 patients with the rising PSA were predicted to fail in the immediate future. Liu from Toronto also looked at the importance of PSA nadir in men treated with HDR brachytherapy used as a boost combined with external beam radiation in the results of 2 prospective trials involving 180 men. And interestingly, she found something very, very similar to what we found here in BC, that a PSA less than 0.2 or 0.2 to 0.4 out at 5 years was associated with a very high freedom from disease as the years passed out beyond 10 and 12 years. PSA 0.4 to 0.8 did not do as well, but not everybody failed, and PSA greater than 0.8 was not a good thing. So the question was, with this background, can we define a biochemical definition of cure following brachytherapy? So what we wanted to do was to identify a PSA threshold value at an intermediate follow-up time point that's associated with long-term 10 to 15-year freedom from prostate cancer for men treated with LDR prostate brachytherapy. And the results of this were published in Radiotherapy Oncology last year, and you can see my co-authors listed. So we combined prospectively collected data sets from 7 institutions. And the institutions included BC Cancer in British Columbia, Canada, the Cleveland Clinic in Ohio, MD Anderson Cancer Center in Houston, National University of Ireland in Galway, in New York, Mount Sinai Hospital, Schiffler Cancer Center in West Virginia, and the University Health Network in Toronto, Canada. In these data sets, the clinical failures and dates of failures were defined by the individual institutions. And failure was considered as any local, regional, distant, or a biochemical failure that triggered salvage androgen deprivation. So we ended up with over 14,000 patients in this combined data set. 8,800 had been treated with LDR brachytherapy alone. 3,100 had that brachytherapy combined with androgen deprivation. 1,100 had it combined with external beam radiation. And 1,300 had what we call trimodality treatment with a combination of androgen deprivation, external beam radiation to the pelvis, plus LDR brachytherapy used as a boost. From the 14,000 patients, patients with less than 3.5 years of PSA follow-up had to be excluded. And that was 4,000 right off the top. We also excluded patients who failed prior to the 3.5 years. So that excluded only 89. And patients who had sufficient follow-up but didn't happen to have a PSA value in our interval of interest, which was between 3.5 and 4.5 years after the brachytherapy, also had to be excluded, and that was another 1,400. So it left us with still a sizable population of patients, 8,936. We defined 4 PSA categories: PSA less than or equal to 0.2, 0.2 to 0.5, 0.5 to 1, and over 1. The start date for our Kaplan-Meier analysis was the date of implant, and the final date was the date of clinical failure or the most recent PSA measurement. We looked at 2 time intervals of interest for this threshold PSA to define cure. The 4-year PSA was any PSA value between 3.5 and 4.5 years, and we had 8,900 patients in that group, and they went on after that 4-year mark, 356 of them, to fail. Our 5-year PSA involved any PSA taken between 4.5 and 5.5 years, and in this group we had 7,700 patients, and 274 of those went on to subsequently fail. So there were enough failures to allow a predictive ability. Our initial analysis used the most recent or the last PSA in the interval of interest, but we repeated it using the first PSA just to see how sensitive it was to that time interval, and made no difference. The quality of failure rates was tested using the log rank test, which assumes proportional hazards, and verified by one that does not assume proportional hazards. And then we validated the results with 3 LDR prospective data sets that were independent, LDR brachytherapy alone used for 366 favorable risk prostate cancer patients from Melbourne, Australia. A 300-patient phase 2 study of LDR brachy alone for intermediate risk prostate cancer from MD Anderson in Houston. And the brachytherapy arm of the ASCEND-RT trial for unfavorable intermediate and high-risk prostate cancer. And these men had all had 12 months of ADT, external beam, plus LDR brachy as a boost, and that was another 166. So those were our validation cohorts. So what was in this, our data set after all the exclusions? Well, about 42% were favorable risk patients, about 50% had intermediate risk prostate cancer, and 8% had high risk prostate cancer. And there were a lot of PSA measurements for each patient. For the 4-year PSA, there were 13 subsequent PSA measurements. For the 5-year, there were 14. And for those patients who happened to have fewer than 10 measurements, the median for the 2 intervals was still 7 and 8. So we had a lot of PSAs to base this on. Now, so if we look at that 4-year PSA by PSA category, if the 4-year PSA was less than or equal to 0.2 nanograms per mil, and there were 80% of the patients in this category, 98.8% are going to be free of failure at subsequent 10 years, and 96% at 15 years. If it was between 0.2 and 0.5, and this is only 11% of the patients, they still do pretty well, but not nearly as well as if it's less than 0.2. And the results deteriorate as that PSA gets higher. And if the PSA at 4 years is over 1, 3/4 of them are going to go on to fail. This is what the curves look like. And this blue one is the one of interest. These are the men with the PSA less than or equal to 0.2 at 3.5 years. And you can see that 96% are free of failure at 15 years. If it was 0.2 to 0.5, it's the red line, 83% will still remain free of failure at 15 years. And these are the guys that had a PSA over 1. If we look at the 5-year PSA, there's 86% of the population in that category of having a 5-year PSA less than or equal to 0.2. And this is even more predictive of cure, in that 99% will be free of disease at 10 years and 97% at 15 years. 0.2 to 0.5, it's only 6.5% of the population, but it's between 94% at 10 years and 85% at 15 years. And again, if the PSA is over 1, 3/4 of them are going to go on to fail. And these are what those graphs look like. And the one of interest is this little skinny blue line here, because we had very tight confidence intervals. And it's 99% at 10 years and 97% at 15 years. The pink line is 0.2 to 0.5, and this one is the guys with the PSA that was over 1 at 5 years. So over 2,800 patients remained in follow-up beyond 10 years. So we had a good long-term cohort. And there's over 450 in follow-up beyond 15 years. So it isn't that we were running out of numbers. The median PSA at both 10 and 15 years is 0.01. So again, this type of brachytherapy is an ablative treatment. The interquartile range at 10 years was 0.0 to 0.05, and at 15 years, 0.0 to 0.02. And as I already mentioned, whether you use the first or last PSA in that 12-month interval didn't make any difference. These are our validation cohorts. On the left is the low-risk patients from Melbourne, Australia. In the middle, the intermediate-risk patients from the MD Anderson in Houston. And both of these cohorts had brachytherapy alone. And on the right is the high-risk patients from the ASCEND trial who had trimodality treatment. And again, our blue line on top is the one for the men with the PSA that's less than or equal to 0.2 at 4 or 5 years. And you can see that this holds true as being very predictive for all 3 risk groups. And likewise, PSA over 1 at 4 or 5 years is very predictive of subsequent failure, again, in all 3 risk groups. So the take-home points are that LDR brachytherapy is associated with very low post-treatment PSA levels. 80% plus of patients will achieve a PSA less than or equal to 0.2 by 4 to 5 years after their implant. And these patients have about a 99% probability of being free of clinical failure at 10 to 15 years. So we recommend that a PSA less than or equal to 0.2 nanograms per mil be adopted as the biochemical definition of cure, which will make it much easier to compare brachytherapy results with surgical series. It's important, however, to note that those patients not achieving this threshold PSA should not be considered as having failed. They just have a higher risk of failure in the subsequent years. So they should continue to be monitored with the understanding that they're at higher risk and we need to follow them. The patients that meet the definition of cure could actually be discharged, if you wish, without subsequent follow-up. This definition was developed also using the LDR brachytherapy data and verified using 3 other LDR brachytherapy data sets and has not yet been applied to other radiation modalities. We suspect that it will hold, but that has not yet been shown. Thank you very much for your attention.